another level of communication. Today we will start our live event, or we will start with a great episode with Dr. Sridhar. He is consultant of neonatology and pediatrics. He will give us a very valuable insight about feeding in infants, plus focus on newborn feeding and infant care, especially in the early days after birth. Welcome on board, Dr. Sridhar.
Thank you. Thank you for inviting me.
Okay. Firstly, we need to know more than details about Dr. Sridhar himself, and let's start our event.
So I'll start.
Yes.
So I'm Dr. Sridhar Kalyanasundaram. I'm a consultant neonatologist, and currently I work at Mediclinic Al Johara Hospital at Alim. I am trained in India as well as in UK, and then I worked as a consultant in UK for 7 years at Scotland before I moved to Dubai, and then I moved to Abu Dhabi region as well recently. So it's my pleasure to be here, and I would refer you to my YouTube channel where I have shared most of the details. So in terms of the approach to the talk today, I'll try to keep it to 30 minutes or so. It's a lot of information to cover, so I'll be mentioning a gist of the topics. We'll have some time for the questions in the end. But most of the points I discussed today, each one of them has an individual video on my channel. So if you search Sridhar K on YouTube, you'll be able to find that. So starting the slideshow now. So when we talk of newborn care, it obviously starts with pregnancy and what we have to evaluate from the mother's health point of view. Where the obstetrician or the midwife calls you to attend the delivery, or if you are reviewing a pregnant woman yourself, make sure you are reviewing all the initial booking, blood results, the antenatal scan. If they have done a trisomy 21 screening, also look at the results of that. The anomaly scan is typically done at 18 to 20 weeks, and if there is any discussion based on any anomalies found, to review that as well. Sometimes the fetus is having a cardiac concern and they get a fetal echo. So make sure these high risk points are always highlighted in the mother's file in a place where the pediatrician cannot miss. The risk factors which can affect the fetal growth as well as which involve monitoring the baby after delivery may include maternal diabetes. About 20 to 25% of the women these days are affected with maternal diabetes, and it involves feeding support as well as screening for hypoglycemia once baby is born. And a similar number depends on where you live, but about 1/4 of the pregnancies may be positive for group B streptococcus, which increases the risk of early onset sepsis in the baby. And there is a prophylaxis to the mother during delivery if you diagnose GBS carriage. So depending on where you live and the local GBS protocols, for example, the American Academy ACOG would suggest that you do the high vaginal swab at 36 weeks, and if the swab is positive, or if the inadequate time for screening, the antibiotic prophylaxis, you need to have criteria. To reduce the antibiotic usage, we have started using the newborn sepsis calculator, which you can refer to later as well. The growth pattern of the fetus is very important because that indicates if there is any risk factor that would need the fetus to be delivered early. Severe growth restriction, especially with Doppler abnormalities, may need premature delivery. Again, if the fetus is severely growth restricted, you may need to evaluate with the antenatal scan in more detail, as well as consider microarray testing, because it may not just be the chromosomal, the trisomies, it can be other microarrays, duplication defects, and so on. So if it is picked up fairly early, you consider doing a more extensive screen. Intrauterine infections are not common, but they have to be considered if there are suggestive factors as well. And one of the recent concepts that have come up, especially if the mother has diabetes or you have a high risk for preterm or twin delivery and so on, is the option of antenatal expression. So we know that it takes 2 to 3 days for the milk letdown to start. And obviously, during this period, the baby, if there is a risk of hypoglycemia, you may need to use formula if the baby drops sugar or the mother's milk isn't adequate for any reason. So antenatal expression is where from 36 weeks onwards, the mother starts expressing milk, the colostrum, and the quantity of colostrum initially is very low, but then it increases. and she can start storing it in the fridge just like she freezes the milk. This can be brought in when she comes for the delivery. And there are two advantages. One is you have the mother's own milk as an option if the baby needs support. And we also have the milk let down coming fairly quickly. So by the second day, the mother should have enough milk. So if you're not already considering this, start using this option for your patients. So at the time of delivery, obviously, one of the crucial decisions is the mode of delivery. And we all know that normal delivery is the best. And we should encourage a normal vaginal delivery as far as possible. There are certain things like breech where there is no risk taking at all. And if the mother has previous cesareans, VBAC, the vaginal birth after cesarean, can be tried if there is an option. Remember that epidural analgesia, though it is beneficial to the mother, if it is given too early in the labor process, it can hamper the progression. Again, inducing the labor before 39 weeks is not indicated unless there is a clear-cut reason for it, because the progress is not going to be ideal. The uterus isn't mature enough, the labor process hasn't set in. So if you induce too early, you are more likely to fail the progression and you may end up with a cesarean. So remember these two things. The timing of epidural should be based on a certain stage of the labor process. Don't give the medication for pain relief too early. We all know that the lower segment cesarean section rates are already quite high. It reaches 40 to 50% in some of the areas and even more. There are many reasons for why the cesarean delivery is increasing. The obstetricians are under pressure, medico-legal concerns, preventing complications of birth, like birth asphyxia. And also, once you become a cesarean for the first baby, the repeated cesarean rate is high as well. So delivery by cesarean has multiple impacts. It has impact on the mother. It has an impact on successful breastfeeding. And also the gut microbiota has been shown to be different whether you deliver by normal delivery or cesarean. And obviously the gut microbiota, we know that has a long-term impact, like the risk of diabetes, obesity, hypertension. These are also significantly impacted by this. So try as far as possible to deliver vaginally and reduce the cesarean section rate. One of the most important recent concepts that has been incorporated in all the guidelines is delayed cord clamping. Delayed cord clamping is a physiologic or natural process. So we started clamping the cord soon after delivery by mistake, and it should have been delayed cord clamping from the beginning. So now we are reversing the mistake more than doing something right to start with. So what happens is the placenta is having the fetal part of the circulation, which gets the gas exchange from the mother and the nutrients and takes it back to the fetus. The lung doesn't breathe when the baby is in the womb. And when the baby is born, the lung expands, starts breathing. And when the lung, which is closed down in the fetus, opens up, it needs additional blood. So what is actually there in the placenta, the fetal part of the placental circulation, is nothing but the blood volume that is meant to be in the fetal lung. So once the lung starts working, this blood comes back. So there is no doubt that this blood belongs to the baby. The other important factor is this is a blood which is very rich in immunoglobulins because the mother transfers antibodies to the fetus, and this blood also has stem cells which help the baby repair, and long-term health is depending on this as well. So delayed cord clamping not only reduces the risk of anemia in the fetus, in a premature baby, it makes the baby less likely to have intravesicular hemorrhage because the blood pressure is maintained very well. And also the immune factors come across to the baby better. Most of you may be familiar with vitamin K injection. So obviously, this is given to prevent early hemorrhagic disease as well as late hemorrhagic disease. The vitamin K is deficient in breast milk, and the baby needs this injection. It's given intramuscular because it's having a depot effect for the long term, for the long late onset hemorrhagic disease. The liver factors 2, 7, 9, 10 for the clotting need vitamin K to be produced in active form. That's why this injection is given, in the absence of which the factors are produced but they are not active, and so the baby has a risk of bleeding. So always remember to give vitamin K and document it as well. So in terms of initial feeding, the most important thing is supporting breastfeeding, and this starts right from the antenatal period. The obstetrician as well as the nurse in the obstetric clinic should guide the mother on what to expect. And antenatal expression, I already mentioned, you can approach that topic where the mother is diabetic or has some other risk for baby needing sugar monitoring. When I say educate the mother on what to expect, it's important for her to know that the milk output for the first 2 to 3 days is very minimal. The mother produces a few drops of colostrum on the first day. It goes up to 3 to 5 ml on the second day and starts crossing 10 ml only by third day. And imagine if you are giving formula feed for the baby, we start with minimum of 30 ml, which is much more than what the baby would get otherwise. So reassure her that the baby is made in such a way that we don't need a big volume of milk to start with. We just need to support the feeding for the first 2 days. The baby has to latch regularly. Her hormones take over when the latching happens regularly and the breast is emptied of the small amounts of colostrum. Not only protects the baby and nourishes the baby, but also encourages more milk production. If you start formula at this stage, for whatever reason, there is a competition. So the mother doesn't get stimulated enough from the emptying of the breast. Her milk production doesn't start, and ultimately you end up depending more and more on the formula. So if there is a medical indication as well, like hypoglycemia or mother being unwell, make sure that she is supported. She should start expressing her milk, and so we start progressing with the feeding. And for expressing, we have hospital grade pumps in most of the hospitals. And if a mother is a working mother, you can encourage her to buy the pump even before the delivery. So she's familiar with the product, she has it with her. In the hospital, obviously, if you're using a hospital pump, it rotates between rooms. You have 1 or 2 pumps for a 10-bed area. And so you may not get it when you want it. And it's better to have your own pump because you'll need it when you return to work as well. And in the first week, it's quite useful option to express because sometimes the baby is learning. They don't empty the breast effectively. And so the milk output may take time. In terms of newborn physical assessment, all the babies are assessed by the pediatricians after delivery, soon after delivery, as well as at least once before discharging. And this involves a head-to-toe clinical examination, face, ears, neck, oral cavity, especially looking for a tongue tie because a prominent tongue tie can interfere with feeding or the mother may need more support even if the tongue tie doesn't need treatment. And looking for a cleft palate. Sometimes the cleft palate is missed and as you examine, palpate or use a tongue depressor to check. So be careful to evaluate these. Examination of the cardiovascular, respiratory and abdominal systems, not to miss any findings. A transitional murmur on the first day is quite common. So if the baby has a normal saturation with a normal femoral pulse, you can wait for the critical heart disease screen at 24 hours, check the baby again, and then decide if you need an echocardiography if the murmur still persists. Speak to the family about cord care. Normally, we request the parents to keep the nappy below the cord area so it doesn't start smelling and wet. It needs anaerobic bacteria colonization to separate. So don't use alcohol or betadine or anything on the cord area and leave it clean and dry. And obviously, when it separates, it may be sticky. You can clean with alcohol swab at that stage and monitor it for umbilical granuloma or other concerns. Clinical assessment of the hip as well as hip screening I'll be discussing as well. So we have the Barlow's test and the Ortolani test, and if there are risk factors like breech or if the baby has a dislocatable hip or family history, you would refer them for ultrasound. Female babies in general are at risk for hip dislocation as well. One of the most important assessments is a red reflex, which makes sure that the red reflex passes through to the retina. So this rules out cataract or other concerns in the visual pathway. It doesn't confirm vision. So you have to tell the parents that the vision has to be assessed as the baby is reviewed in the clinic based on how the baby responds, fixing, following, and so on. Anal patency shouldn't be missed as part of the initial assessment. If there is delayed stooling, reassess this area and you may need to get a surgical opinion because Hirschsprung disease or other problems can cause delayed stooling and abdominal distension, vomiting, and so on. Assess the genitals. Ambiguous genitalia has to be assessed, and in a male baby, undescended testis is not uncommon. Sometimes you have penis-related problems like hypospadias, cordy, which may need a urology opinion as well. Limbs and musculoskeletal assessment are important, including the assessment of the hips. Positional talipus, where the feet is turned in, is common, which usually self-resolves. Simple stretching may be enough, but if it is more than positional and it doesn't correct back, you need immediate orthopedic review. Check the spine carefully for defects as well, and review the antenatal scan findings. Some of these babies have renal pelvic dilatation, which may need postnatal scans. So review the antenatal scan to get to know when you assess the baby as well. So there are different aspects of newborn screening, and all of you would be familiar with the critical heart disease screening, which has become quite prominent in the past 10 years, and it's almost universal. So this is basically a saturation testing in the upper and lower limb around 24 hours of age. Before 24 hours, the PDA may be still open, and it's not ideal in the transitional circulation because you may have more false positives. So if the saturation difference between the upper and lower limbs is more than 3%, or it's less than 95% on repeated occasions, it's a concerning result. If it is less than 90% in any reading, it's abnormal, and all these babies should be evaluated by the neonatologist and possibly by the pediatric cardiologist, and the heart scan may be needed. It only picks up the critical heart disease, which is mainly the cyanotic heart disease, but the left to right shunts like VSD, PDA may still need to be picked up by the murmur and other clinical findings. And again, inform the parents that the newborn assessment may not rule out all heart disease because the murmur may not become prominent till the first week or two when the pulmonary pressures are dropping. The hearing screen also is done universally in most of the countries, and the initial screening test is usually the otoacoustic emission. If there is a failed hearing test in the beginning, it may be because there is fluid in the middle ear, and these babies are referred for a repeat otoacoustic emission after 2 weeks. If the baby fails 2 otoacoustic emission, you go for auditory brainstem evoked response or BERA, which is more specific, and then you may need an audiology evaluation as well. I mentioned already the hip screening. This is usually done by ultrasound of the hips around 3 to 4 weeks by either your radiology team or by orthopedic, depending on your setup. The newborn blood spot screening is very important, and this is the way the samples are collected. In UK, they call it the Guthrie or PKU test, and different names in different setups. Heel prick sample is preferred than a venous sample because the blotch should be right on the dot rather than spreading around it. The venous sample can drop more fast, and so that can spread, and these drops can merge. That makes it more difficult to take a correct sample. Previously, we used to wait till 48 hours, but nowadays we can do it between 24 to 48 hours as well. So we don't miss any babies before they go home. Ideally, the baby should be on feeds when we are doing this. So if the baby is admitted to the NICU, we do a first sample initially at admission, and then when the baby is on full feeds before discharge. In a preterm baby, after 2 weeks, we repeat the sample as well. A good system should be in place to make sure these results are reported back in a timely fashion. In UAE, for example, the tests are done in a central lab, and the results come to the hospital, and then the consultant who is requesting it gets called if there is an abnormal result. The thyroid, phenylketonuria, G6PD, galactosemia, many other metabolic disorders are also screened as part of it, and thalassemia, alpha thalassemia can be part, sickle cell disease can be included in the hemoglobin electrophoresis, which is done as part of this. The other important part is blood spot can be stored, and if the baby has any future concerns, we can test for it as well. In terms of regular newborn care, as part of the pediatrician's advice, the parent should be informed an overview. Regular bathing is not essential in the first weeks. You can bathe the baby once in 3 to 4 days, and lukewarm water is adequate, not warm, too much of a warm water. Dry skin is common, and if you notice dry areas, you need to start using emollients, and stress that emollient should be used on wet skin because it retains the moisture rather than giving the moisture effect. So put some water on the skin, dab the skin with water, and apply the emollients. If any area is more dry, you need to repeat this more often, so educate them on this. Nappy care, as well as this baby's milk intake increases, they start passing more stools, and physiologic lactose intolerance is common in this stage. So teach the parents not to overfeed, allow the baby to start digesting the milk well. And when this stool frequency is more, the stool is acidic and frothy as well, so you may have a higher risk of nappy rash unless you look after the nappy area well. So you can use a barrier cream like Sodo cream, for example, and avoid wipes as the pressure may be more. You can use water and cotton to clean the nappy area, it's better. If you do see a nappy rash, you can discuss with the doctor about how to manage that as well. And most of the time it's not infected, so reviewing the technique of nappy change can be adequate. Feeding pattern is very important. I mean, in a breastfeeding baby, we allow feeding on demand fully. But of course, if the baby has a very quick feeding pattern like hourly, it's not ideal. So you try to wait at least 2 hours between feeds so the baby starts taking a bigger volume. And this encourages the baby to start sleeping better and paces themselves better. So the range of 2 to 5 hours between feeds is quite reasonable. If you are needing formula or express milk for any reason, you can aim for a similar pattern, adjust the volume. One word of caution here, if you are using formula milk, don't follow the instruction on the tin as for the volume because each baby is different. You have to titrate the volume according to the baby's own growth pattern. So if you follow the instruction on the tin, you may find that you're giving far more than what the baby needs and end up with reflux, colic, and other problems. Immunization also needs to be explained. You give them the booklet when the baby goes home. And the BCG reaction, many parents aren't aware, especially if it's their first baby. So educate them that after 4 to 8 weeks over the left shoulder, you may get this reaction. It's a normal change. The blister opens up and the scar forms with time. And hepatitis B vaccine is given at birth as well. And the further schedule, you can educate the family on where to get it and when to get it. All the babies receive vitamin D these days, whether they are breastfed or formula fed. The reason we give formula fed babies vitamin D as well is because though the vitamin D is there in the formula milk, they need to take around 1 liter to reach the required 400 units per day. So it's safer to give them the supplement. A little higher dose doesn't harm them. And in breastfed babies or in mixed feeding babies, of course, you need to continue because breast milk is low on vitamin D. And vitamin D has a big role to play in their general development, bone development, as well as immunity. So we don't want to deprive them of a crucial vitamin at this first 2 years. Iron supplement after 4 to 6 months is considered in vegetarians and in babies who have risk of iron deficiency. But educate the families about the weaning foods which are rich in iron as well. Early supplementation of both vitamin D, iron is considered in the premature babies who may need multivitamins, calcium, phosphorus as well. We do screen them for bone health, especially the babies below 32 weeks, and you need a separate approach for the premature babies. So where exclusive breastfeeding is not possible at any stage, you consider infant formula, but be clear about hygienic preparation, sterilizing the bottle, etc. Because infection is one of the biggest problems, especially in the developing countries where hygiene could be an issue. Even contaminated water sources can be a big problem. So you need to boil the water and then use sterilized bottles every time, and how you handle the bottles as well. So the parents need clear information on that. When you give bottle feeds instead of breastfeeds, in breastfeeding, the baby regulates the intake much better. But here we are looking at a volume, we are trying to feed the baby. Each feed is different, each baby is different. So invariably, there is a risk of overfeeding. Educate the parents again that over diluting or making the formula too concentrated is not safe. So they need to know the exact proportion, how to mix the formula. When we have overfeeding, we have a higher chance of colic because the baby may not digest the milk well. The lactose intolerance-like symptoms may aggravate the colic. Colic also has gut-brain axis-related concerns, and it's a maturational thing which passes by 2 to 3 months. So the parents have to be reassured most of the time you don't need medications for that. Reflux happens because of the overfeeding most of the time, or where the baby is at high risk for relaxed gastroesophageal sphincter like a premature baby. So educate them on positioning and how to avoid overfeeding by spacing and not focusing on the volume that is dictated. In terms of which formula to use, we have term formula, which is the regular ones, and we have the comfort formula, which have reduced lactose and maybe partially digested protein as well. So it depends on how the baby is responding. Nowadays, parents are considering using goat milk-based formula. You can consider using it, but there is not a huge benefit compared to the cost you would be paying more for it. In terms of supporting breastfeeding, remember any baby needing formula, you need to encourage the mother to express and maintain her milk output as much as possible. So you rely less on formula and manage to get more of breast milk. So this is a key factor as well. So never directly support formula, support breastfeeding as best as you can, and use formula only if essential. In terms of solids, typically weaning foods are introduced by 6 months. This is a recommendation for the WHO as well as many world bodies. And in some situations in working mothers where she's almost reaching her milk output, we can consider starting at 4 to 6 months, but it's to be started with the fruits, vegetables, and so on. Sorry about the noise, it's a fire alarm. The baby should show readiness to take solids, and homemade pureed foods are preferable. Obviously, it gives more taste, more variety, and remember that picky eating is provoked when we keep giving the same food regularly. So, giving homemade foods with variety makes the picky eating less likely as well. And we should educate the parents about a good balanced intake. Most parents are not aware of protein in the food, so they may start giving banana based foods or pureed banana and so on, which doesn't have any protein. So they need to be shown what is a good mix of protein, and they should progress as tolerated. Again, we can start with 1 to 2 feeds and progress quickly to 3 feeds a day. And they should also be shown that as the solids increase, the milk has to reduce. It's very important to give adequate water at this stage, because if they don't get enough water, the babies invariably get constipation. So roughly 20 to 30 ml of water with each meal is adequate, but babies can take the sippy cup for the water. They can increase the intake as they need. There is no reason to delay the allergenic foods. Even if there is a history of allergy, eggs, nuts, seafoods can be introduced from 6 to 7 months, and these are protein-rich foods as well. So it takes care of the protein intake, especially growth is a concern, increase the protein intake. The milk intake should reduce as the intake of solids increase, and we should encourage baby-led weaning or baby participation. It may not be purely baby-led, but you try to involve the baby and progress as they tolerate. Fresh milk, recently the WHO brought in an update that it can be considered from 6 months onwards. Previously, we used to say 12 months. But remember that the formula milk is still better in these stages as it's supplemented. And consider fresh milk, for example, if you run out of the formula for a day, you can give fresh milk instead. And of course, for cooking, you can use dairy products, yogurt, cheese, butter can be used as well. No added salt or sugar for the first year, preferably, because they lead to taste preference, and there is enough salt in the milk as well. Sugar is never a good food, and babies who get used to sugary foods may not eat the other foods, so picky eating becomes more. So there may not be a scientific reason apart from the reason that you favor sweet foods which are not healthy. So sugar is only carbohydrate. And we discussed this already. Fiber content as well as water content reduces constipation, which is a common problem as well these days. So don't give processed food all the time. Focus on homemade food, more variety, more fiber. Mashed peas, mashed corn, etc. give a good fiber content. And don't forget dental care and hygiene right from the early infancy. So even after the breastfeeds, you can get used to cleaning the mouth. And dental care, once the gums start showing changes of dentition, of course, the timing of dental eruption varies, but you start cleaning the gums with silicone brush. And once the teeth are erupted, start brushing. Don't wait for the birthday or anything. As soon as the teeth is there, you should be brushing. And remember, the babies don't spit it out. Swallowing the paste with low fluoride is fine, because you do need fluoride for the development of the teeth. I mentioned picky eating briefly. Mostly it's related to baby temperament, but the parents contribute by giving in to tantrums. So remember that picky eating is a kind of a discipline related issue, and an approach to discipline, parents should be aware of it. There are videos on my channel on infant discipline and how to approach it as well. So start from 6 months onwards, don't delay disciplining. And it doesn't mean you have to be very strict. You just have to be aware of how to approach situations, don't give in to tantrums and so on. And in general terms, rotate the different foods. Don't give the same sweet jar foods every day. The tastes and textures, for example, you can introduce bread toast at a certain stage of 9 months or so, some granular food as well. And encourage the baby participation, avoid forcible feeding, accept that there are times when the baby is less hungry, and don't finish the food just because you took something, and reduce the milk intake. That's a common factor as well, that baby doesn't really need more because they're already taking too much milk. So as you increase the solids, reduce the milk, you'll automatically see an increase. Don't get into unhealthy habits of rewarding with sweet foods just to make them eat better. That's not a good culture at all. Lastly, a few tips related to infant development. So screen time is very negative for the developing infant in the first 2 years. So almost zero screen time. If you have a video call with a relative, you can show the screen briefly, but there is nothing educational in the educational videos at this age, because babies are meant to learn from interaction. So please don't show them videos thinking alphabets and counting is going to make them any cleverer. It actually makes them behave different, and it's not good for them. Start reading to them, because reading and activities like farm board or jigsaw, which engage their attention span, it's much more fun for the kids to run around and play physically, but to sit and engage needs attention. And once they get into this habit, it's easier to maintain when they get older, and they learn better, they speak better when you do all this. And a stimulating environment involves all of this, and the whole family sits together, and this focuses on the progress that the infant makes and what life skills they learn, rather than structured learning like teaching them alphabets before. So you're not going to get anything by making them count to 10 by the time they're 2. So focus on the essential parts and social interaction. All the babies should get regular reviews with the pediatrician or GP on their growth, development, immunization, nutrition, dental hygiene review, etc. And this should be part of their holistic care. So whenever the pediatrician reviews them, it's part of their responsibility to include the same discussion. So we take every opportunity to teach them about the important do's and don'ts on child feeding and development. So with this, I'll stop sharing and we can have some questions.
Firstly, I need to thank you so much because this was perfect presentation, not only from psychological, from physiology side, but also some tips for psychological factors. So thank you so much, Dr. Sridhar. And in this section, we will have some questions we received from Medsynapse community. Firstly, what are the most common nutrition deficiencies in newborn, and how can they be prevented?
I mean, most of the time, unless the baby is premature, we don't expect a deficiency. Vitamin K, I already mentioned that they are, especially if the mother is on anti-epileptics or there is a risk factor in the mother, they may be deficient in vitamin K. So there is an accelerated early hemorrhagic disease and we need to target them. If there is a hemolysis in the baby, there is exaggerated jaundice, we sometimes give folic acid supplement. But vitamin D is started for all babies to prevent deficiency, not because they are deficient. And remember that the pregnancy is an active process. So even if the mother is deficient in nutrients, the placenta transfers these essential foods to the baby. In a premature baby, we need to focus on calcium, phosphorus intake as well.
Okay, the second question is how can we identify and address food allergies in newborn and infants?
Food allergy is an important concern. I mean, many parents have it. Remember that most of the time this comes to notice because of eczema developing on the skin. Many parents confuse eczema as food allergy, but it's not the case. Most of the eczema happens either because you have a tendency to dry skin or because you have inadequate skin management. So if you start moisturizing the skin early on, you may not see the skin allergy. Most of the food allergy in the babies happens with GI concerns. So you may have the baby not tolerating the milk well, they may have blood-stained stools, more of crying episodes, reflux, and so on. So typically cow's milk allergy is a common concern. Lactose intolerance is not an allergy by itself, and I briefly mentioned that all babies have a degree of lactose intolerance in the beginning. Then they get enough enzyme to digest the lactose. So keeping the dose of the lactose, the milk level low in the beginning when they are learning is a good point. Apart from that, if the baby has blood in the stool or the colic is more severe, doesn't respond to the usual measures, you think of milk allergy, and then you may consider even in a breastfeeding mother, it can happen because the milk protein can come through her breast milk to the baby. Apart from that, the other food allergies, egg allergy, fish allergy, suppose the baby doesn't respond to milk elimination alone, the mother may need to eliminate those. And if you need formula milk in an allergic baby, you need a specific formula. As the child grows, when you introduce other foods, seafoods, nuts, and so on, you have to watch for allergy. And some of these can be diarrhea-like presentations, FPIs, we call it food protein-induced enterocolitis. So you may have diarrhea or blood-stained stools, and baby may even go into acute dehydration with these. So that is one presentation. Rash coming up later on. Anaphylaxis, we call it acute allergy, where there is breathing difficulty and so on. So these are things to monitor as well. So it's just a nutshell of what you look for.
Okay, the second one, the second question is how can parents ensure their infants are getting enough vitamins and minerals?
I already mentioned it, that vitamin D and iron are the two important supplements. Vitamin D from birth and iron, especially if your nutritional intake is not adequate or in a premature baby, you start giving by 4 to 6 months. In vegetarians as well, you may routinely supplement the iron. The other supplements are not essential. I mean, omega-3 or vitamin C and all are not shown to be evidence-based. You can give a multivitamin if you want to give, but it's not necessary. Most of the insurances do not cover that as well.
Okay. How do you monitor and interpret growth charts for infants?
What chart?
What growth charts? Yes.
Growth chart. Again, there is a detailed video as well as I have a parenting blog. I mean, this is shared in detail on that. You can review that. But obviously, during each visit to the pediatrician or during the vaccination reviews, you would be checking the growth pattern and plot them on the growth chart. The WHO growth chart is the best for the first 2 years because it's based on breastfeeding babies and you don't overly target. When I talk about overfeeding, remember that the baby's feed intake and the growth pattern depends on the baby's own requirements and the centile. If a baby is small at birth, they may continue to grow small. Some babies do catch up, but you don't force them to feed more to catch up. So that's the key thing. So there are growth apps as well. You can download and plot the growth and you can monitor that to get an idea. So if the growth chart is going steeply upward, that means you're not doing something right. And you don't necessarily need to come to the average. I mean, some babies stay on the smaller side and they're still perfectly healthy.
Okay, so that's the question will be, what are the key components of comprehensive infant nutrition assessment apart from length and weight?
I mean, general well-being of the child and also a review of what feed they are giving in terms of wholesomeness. Assessment of the stool pattern, as I said, constipation is often linked to improper weaning habits like not giving enough water. Dental review should be part of your eating assessments as well. So growth and development are the important aspects and discussion during the history taking. So make sure they're understanding the concept of a balanced diet, the protein intake, which are the protein-rich food, which are the iron-rich food. So you can speak to them about those aspects.
Okay. At the end of this event, I need to thank you many times for this perfect presentation, and there are a lot of consideration related to neonatology. So I hope to create a full series related to neonatology managed by you, Dr. Sridhar, and thank you so much.
Thank you. It's my pleasure. Thank you so much. Take care.
Thank you.